Okay, hi everyone. For those of you that I have not met, my name is Arash Asher. I'm the director of the Cancer Rehabilitation and Survivorship Program here at Cedars Sinai. Thank you all for joining. This series is called our Wellness, Resilience, and Survivorship series. And for those of you that have not participated before, this was meant to be an outward-facing community event with the goal of bringing in topics that we think are really important and of value and hopefully interesting to our patients and to our community. So, for example, recently we had a topic about some of the controversies about psilocybin and psychedelics. We had another topic about the experience of awe and how important this can be for our well-being and survivorship. And today, um, I'm really grateful to have our panel that I'll introduce in a moment talking about the role of exercise in cancer. And it's been entitled Moving Through Cancer Evidence and Inspiration. So thank you all again for joining. And so what I'm going to do is I'm going to introduce our panelists. And after that, we'll watch a short documentary together, and then we'll have some time for some discussion and presentation from Dr. Schmitz. And so again, I am so honored to be able to welcome Dr. Catherine Schmitz. For those of you that have heard me speak about this topic, invariably I was quoting one of her studies over the years because she really has been at the forefront and the lead exercise oncology researcher for cancer survivorship. She is a professor of medicine in the Division of Hem-Onc at the University of Pittsburgh School of Medicine, as well as the director of their exercise oncology program. Her work is really focused on the role of exercise in physiologic and psychosocial outcomes for patients living with and beyond cancer. And again, I really can't emphasize enough to our patients in our community how much of a giant she is in the field of exercise oncology. I know I think from what I reviewed, serving on at least three large NIH trials just now. She's run numerous trials throughout her career. She's focused on topics really wide-ranging from the role of resistance training for patients with lymphedema, which was, I remember at the time, a source of great anxiety and distress for many, to improving outcomes for cancer survivors, to discussing the role of exercise in preventing cancer. And if you're familiar with medicine, um, she has published in absolutely the highest impact journals in our field, New England Journal of Medicine, JAMA, and the like. She's published over 350 publications. And I think for me, what's maybe even more impressive is not just the sheer number of publications, but she's really changed the standard of care. So if you look at our guidelines, including, for example, what I often share with many of our own patients, the American College of Sports Medicine, she was the lead author who helped implement and bring exercise as part of the oncology care plan. She has been the recipient of numerous awards, including the Distinguished Scientist Award from the Society of Behavioral Medicine to the American Cancer Society's prestigious Clinical Research Professor Award, and also recently inducted as an honorary fellow to the College of Royal Surgeons in Edinburgh, Scotland. She earned her PhD at the University of Minnesota, where she also completed a postdoctoral fellowship in epidemiology. And I think, I may be wrong, I think she's the first guest we've brought that has her own Wikipedia account profile. So I'm not sure if we've had the privilege of introducing someone in this space before. So, Dr. Schmitz, thank you so much for joining. Second, but certainly not least, the person who really brought us all together and made this happen is Sherry Annis. She is the Healthcare Development and Community Engagement Director for the Fund for Sustainable Tomorrows. She has focused on life sciences in her independent consulting practice, and Sherry brings to the Fund for Sustainable Tomorrows her experience in healthcare policy. She started off as a White House intern, moved to the U.S. Senate Commerce Subcommittee, And in 1987, she founded Ennis Associates to work with emerging biotech and emerging pharma companies. She has a degree in psychology from the University of Pennsylvania and has studied at Columbia, Stanford, and Harvard in areas including executive finance, design, and business programs. She's led social justice outreach programs as well as several autism, oncology, and other healthcare educational projects for the fund. And she's also worked with us. She actually helped us create our Emerging from the Haze video series. And she's also worked with other leading centers such as MD Anderson and UCSF. She's allowed me to share that she's been quite open about her personal story as well. And I really think that's why she's brought us together. She's been open about her being a woman that's lost her husband to pancreatic cancer, and she herself has successfully been treated for and has survived breast cancer. And because of that experience, she really was the catalyst for bringing and producing the fund's first independent short feature, which we're going to watch momentarily, Moving Through Cancer. So again, thank you both so much. I think I'm going to start and calling on you, Sherry, since we're going to watch the film as a small little community here. Do you want to give a few introductory comments before we play?
Sure. Well, in the process of helping my husband fight his battle against cancer, I learned about the exercises medicine in cancer movement. And fortuitously, I was introduced to both Dr. Asher and Dr. Schmitz. And both of them were leaders in the field, and both of them were not only my inspiration in terms of spreading the word that getting moving and moving through cancer was key, but also they were the inspirations in my own personal journey because I had been introduced to so many of their patients and I saw how well exercise was contributing to the quality of life of their patients. So it was having worked with my husband, no one told us that. Nobody, he was an ex-athlete and no one said, keep him moving. And so I decided not to do another hero film, but to do a film that would explain to the cancer community, to patients, to families, to caregivers, that there was a robust body of evidence underlying the thesis to get moving. And I wanted to detail some of the model programs and patient experiences across the world.
Thank you, Dr. Schmitz. Any comments, or should we start by playing?
Let's start that
Okay.
film.
So hopefully we've sorted out the technical issues. Joanne, if you don't mind, let's try to play the film.
These dragon boat racers, pickleball and soccer players, master swimmer, mountain climber, and I, an Olympic gold medalist, all have something in common: cancer. We're all survivors, not weekend warriors, not professional athletes, and we're actively moving through cancer. Surprisingly, only about 15% of cancer patients are told that exercise is medicine. That's a staggering small number, a fact that flies in the face of robust science. Hi, I'm Scott Hamilton, and for those of you who don't know me, I was blessed to be able to win 4 U.S. championships, 4 world championships, and an Olympic gold medal in ice skating. I also toured for 20 years and was blessed to be able to cover 9 Olympic Games for television. I'm also a cancer survivor and a 3-time brain tumor survivor. Here's what I've learned. A cancer journey is different for every single person that goes through it, but the one thing that we all share is you have to have strength, courage, a lot of laughter throughout it. I never want to give cancer anything at once. In fact, I only want to give it what it doesn't like, and exercise is top of that list.
I thought
that people who go to the gym was people that they didn't have anything else interesting to do.
20 years ago, Luz Pena learned that she had breast cancer. The advice she got from her doctor? Just rest.
Because the treatments were hard, they told me, you just need to sleep and relax.
10 years later, Luz learned that she had ovarian cancer.
The recommendation now was exercise, be active, walk. That's going to be your best medicine.
The benefits of exercise in both treating and preventing cancer have been known since the 1970s, and recent studies have further established the link between physical activity and a lower risk of many cancers.
We have outstanding epidemiologic evidence that tells us that exercise causes about a 10 to 20% reduction in the onset of 7 different common cancers, including breast, colon, endometrial, bladder, kidney, esophageal, and stomach cancers.
Exercise oncology is a new frontier. Researchers throughout the world are adding insight into how much exercise is right for each patient and why it works.
Exercise affects so many different body systems. It affects the immune system. It affects metabolism. It affects the cardiovascular system. It affects the pulmonary system. It affects the digestive system. It affects the musculoskeletal system. And all of these things are affected by all of these new cancer drugs. Exercise could be a constant that helps us to control the side effects that we don't even know about yet from newer cancer drugs.
To get up and move, to me, is like the single most important thing you could do for yourself while you're undergoing treatment.
Swimmer and 3-time cancer survivor Susan Helmrich has had 8 cancer-related surgeries and has gotten back in the water after each one.
Hard as it is, if you have chemo or radiation or surgery, you're tired. Your body has been through a lot, and it's really hard to say, I'm going to get up and go running. You don't have to do that, but you have to move. And for me, it was swimming.
Patients of all ages and fitness see their quality of life improves with exercise.
Radiation as well as chemotherapy can be incredibly fatiguing. The biggest gains are really, we think, from the sofa to the sidewalk. And when you do that, you may very well find that your energy improves, that you're able to tolerate your treatment better and have an easier time getting through it. The best cancer treatment in the world is useless if you can't get through the cancer treatment.
Not long ago, cancer patients in rehab were advised to exercise after surgery and radiation. Today, leading cancer centers urge patients to be active during treatment and even before their cancer regimens begin in what are called prehab programs.
The term prehab was very new in medicine and in oncology. Essentially, we're going in early, soon after diagnosis, to evaluate patients' level of function. Prehab programs may include any combination of physical activity, exercise, nutrition optimization, and also very important mental health and well-being.
Across the cancer care continuum, the total number of studies linking exercise and positive outcomes has grown to over 15,000 in less than 2 decades.
For at least 3 cancers, probably going to grow as we do more research and we have more information. We're learning that you could reduce the chance of the cancer coming back. And this may be as high as 30 or 40% or higher if we get the right amount of exercise.
Research is also starting to show how much exercise is needed to stay cancer-free.
Specificity is important because we don't tell people to just go get some chemotherapy. We don't tell people just go get some radiation. We tell them we're going to give you these specific drugs on these specific days, at this specific interval, at this specific dose, and we need to dose exercise similarly, precisely, like a medicine, because it has that kind of potent effect.
The American College of Sports Medicine recommends moderate aerobic activity, 150 to 300 minutes a week, and resistance exercise twice weekly.
We were taught for a long time that muscles are important so we can lift things, which is true. But it turns out that when we're contracting our muscles, when we do a squat, when you do a curl, when you swim, that your muscles are also releasing or producing something. and they've dubbed these myokines. And what's amazing about myokines is that they seem to have anti-cancer benefits.
The more we exercise, the more myokines we produce. And even when we're resting, myokines keep cancer at bay. They slow the growth of cancer cells and they're spread to other parts of the body. Clinical studies at MD Anderson found that patients who were able to exercise during treatment showed improved physical function.
There's preliminary evidence showing that there's improved changes within the tumor vasculature so that there's more uptake of chemotherapy into the tumor. And also we found some preliminary evidence that there's improved immune cells within the tumor also, which might confer an anti-tumor effect.
At MD Anderson's Shadler lab, prehab trials confirmed game-changing findings originally seen in mouse models of pancreatic cancer.
Patients who exercise had more mature blood vessels so that hopefully there's more uptake of chemotherapy into the tumor.
Even in glioblastoma, exercise can make a difference.
The brain controls everything that we do, especially our motor function. And many patients can have not only weakness of a certain arm or leg, but they may have difficulty with balance and coordination.
Dr. Chang founded Workout for Wellness, a program called WOW at UCSF in San Francisco, California, to help brain tumor patients stay active during and after treatment.
Patients love this idea because it gives them that empowerment of control that they have now lost when they're diagnosed with a brain tumor. All of those aspects of taking care of themselves, that how important that is in terms of their tolerance of treatment, but also improving, their sense of well-being.
Exercise physiologists and specially trained professionals play an important role in customizing programs.
Each person's individual cancer diagnosis and cancer treatments give us a direction in which we should move with their exercise programming. So patients with breast cancer, they might want to focus more on improving their upper body strength and range of motion. Patients with lung cancer might want to focus more on their cardiovascular health.
At the Maple Tree Cancer Alliance, instructors help patients get back to everyday life.
When you're told that you have cancer, most people feel like that's it for you. And I have to be honest, I had two sides. I had the side, okay, it's time to fight, or that side, oh God, I have cancer and will I make this?
After JVET completed treatment for lung cancer, her oncologist referred her to Maple Tree.
I was very exhausted and was just wondering how the program would be. Even can I do it? When I first came in, I was coughing, I was weak, barely could get on the treadmill, barely could get on the stepper. I really like how they document when you first come in until you graduate those 12 weeks. And it was inspiring for me because I saw where I was and how I was moving along.
Dr. Karen Wonders is the CEO and founder of Maple Tree, the first cancer-specific exercise clinic to partner with a hospital's on-campus cancer program.
When we first started doing this exercise oncology, less than 2% of cancer patients were exercising or even being told to exercise during treatment. And that was as late as 2018.
In Dayton, Ohio, at the Kettering Cancer Center, Maple Tree created a new model, and exercise oncology became an integrated part of cancer care. Today, Maple Tree is the largest provider of exercise oncology in the world.
It allowed the patients to come and to do exercise where they were already getting their treatment. And being that we were on site right down the hall from their infusion centers, it made it seem like this was integrated and this was expected as part of their plan of care. In that first location, now we're working with about 60% of their active patient population, which is a huge jump from the 2% where we started from.
Today, Maple Tree clinics can be found in 60 hospital settings and in 14 different countries.
Before I got to Maple Tree, I was watching my energy level go down, 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 and I was a person that used to exercise frequently.
Metastatic prostate cancer, like many other cancers, can make it difficult to do the things you once did with ease.
Now with the treatment, I'm getting more used to the ups and downs of the energy level. It's like riding a surf. You never know how it's going to be every day. I'm back to walking 1 to 2 miles almost every evening with my wife, which I haven't been doing at all.
Not all hospitals have programs like Maple Tree's, and not all doctors are familiar with the research.
The barriers that we see in implementing a program like Maple Tree, number one is cost. This is not yet reimbursable by insurance, and even though we have data to show that there's healthcare utilization savings and cost savings associated with our program, it still is a cost to the hospital to put in the program, to staff the program, and to make it available for their patients.
Finding cancer exercise programs and trained specialists isn't always easy.
Right now, there's a dearth of those programs, and it's a total patchwork quilt. If you live in a particular setting that is kind of a mid-sized city, the likelihood that you're going to have some kind of exercise oncology programming is greater than if you live in a great big city or if you live in a rural setting. You need to fix that. That's an inequitable situation.
Some people, because of their background or their culture that they come from, are less likely to talk with others about the cancer. In some communities, it's still more of a stigmatized condition. So it's a challenge to really reach those people and get them engaged in programs like this.
That's where grassroots organizations can step in with outreach community programs. In Beaumont, Texas, with MD Anderson as its partner, The Gift of Life hosts bilingual classes that include exercise.
En Active Living After Cancer, cada quien inicia en el punto en el que se encuentra.
They are tackling head-on the inequities in our nation's healthcare systems, and they're pointing the way to creative solutions.
That means overcoming the obstacles that they face, whether it's childcare, transportation, even many times helping them pay utilities so then they can direct their attention to being able to care for themselves. And that's where we think this program and how important it is to come out into the community and address those vulnerable, really at-risk populations.
Personally, I know going through a cancer journey, you're just doing the best you can each day. You're hoping for the best care. Some of you are getting it, some maybe not the best, but you're doing the best you possibly can to push back against this disease. And the one thing I can tell you is you're in charge of how you live each day, and getting up and moving, getting up and exercising, getting up and just doing whatever you possibly can will help you in ways that you cannot even imagine. Programming today ranges from group classes to personalized instructions in person and on Zoom. In Copenhagen and in many cities worldwide, breast cancer survivors compete in dragon boat regattas. Camaraderie, they say, is key when cancer often isolates you from friends and family.
We're here together. We do this together, and we all have a common history, and we don't need to talk about it always. And it's a huge boat, and it's heavy, but we can move it. And it's so great that you have so much power together. It's the best thing I've done for many years. This takes the breath away from me.
If a cancer survivor says, you know, I want to exercise more, but I just hate going to the gym, I don't say, well, you need to go to the gym. I say, what do you like to do? It's very important to factor in the person's enjoyment and willingness and what they're motivated to do in order to build some lasting behavior change.
At MD Anderson, educators at Active Living After Cancer, or ALAC, give patients pedometers to track their walking. Luz started at 345 steps daily.
The health educator told me 10,000 steps is the goal. And in my mind, per month, 346 to 10,000 steps, how can we do that?
A breakthrough came when she was told to set a goal.
Running 1 block, running 2 blocks, that's good. But then running a 5K, running a 10K, and then going through the half marathon took me a whole year. So that was month over month over month.
It's a little overwhelming at times to be dealing with it. You know, just it comes when it comes, and you know, career stops in its tracks, everything changes.
Kathy began working with her trainer, Beth Kamsky, as part of a study at the Penn State Cancer Center.
Metastatic Breast cancer is a lifelong diagnosis. It does not go away. She has never stopped trying. Her exercise has gone from using bands and walking long distances to having to do exercises in a chair and some light stretching. It is absolutely unnecessary to go out and buy a bunch of equipment if you want to start exercising. There are things at home that you can use: soup cans, water bottles, jugs of milk.
There's better outcomes with exercise, and it just helps so much mentally too. I'm not going to stop now because cancer is in the way.
I think a lot of people still believe that exercise is incompatible with having a cancer diagnosis, and we really need to change that.
Exercise guidelines for cancer patients have been published by several of the most prestigious medical groups in the world: the American College of Sports Medicine, the American Cancer Society, and the American Society of Clinical Oncology.
It is so important that this not just be a UCSF or a specific institution that is championing it. This has to be every institution that takes care of cancer patients.
I don't want to sound like Pollyanna, and I don't want to sound like, oh, cancer, made my life better, because it didn't. But you have to get through the darkness, and you have to get through the hard stuff. Most people will come out the other end, but getting through it is hard. You've got to push yourself, and you have to know that taking good care of yourself and pushing yourself through it is going to be the best thing you can do.
Cancer tries to break you and trick you into giving up. Like many of you, I was sapped of all my energy and confidence. If I can leave you with one thought, it's take the risk. Get moving. Start slow, set small goals, pace yourself, and then pat yourself on the back. Can I do today what I did on the ice in 1984? No way. But I can move, and you can too. And for all of us, it's different. Whether you skate or swim or walk, whatever it is, just get up, get out, get active, and you'll be amazed at how much better you feel.
I think we could all agree, Sherry, this was a really extraordinary effort that you undertook to bring this free. And this is available, somebody asked in the chat, online, free of charge, correct? And we could share the link with everyone. Sherry, you're on mute though.
I hope it just unmuted. I tried a second time.
Perfect.
Okay. If you write Moving Through Cancer YouTube, there are 2 places that it will direct you to. And yes, we can provide the link as well. And we can even provide a QR code that takes you directly to the link. And I raised the money to make the film so that anyone, any patient, any clinic, any organization can see the film and share the film. So the more it's shared, the better job I did.
Okay, thanks again, Sherry. So I'd like to hand over the baton to Dr. Schmitz. She's going to give us a brief presentation, and then we're going to have some time to answer some questions and just have a brief discussion. So Dr. Schmitz, thank you so much again.
Okay, I'll try to be as brief as possible. I already saw a hand up, and I know that people will have a lot of questions and comments. So I'll try to be as brief as I can be. But basically, here's some of the science behind what you just heard in the film. So there's something that was shown that Sherry uses. She uses this graphic in the film, and I wanted to give you a little backstory about it. So the first human clinical trials that happened in the field of exercise oncology were at the Ohio State University by nursing researchers back in the 1980s. In 1996, the first review was published on this topic, and they found 4 randomized controlled trials. I published the first meta-analysis in the field in 2005, and there were 22 trials at the time. By the time we did the first ACSM roundtable, there were nearly 225 trials. By the time we did the second ACSM roundtable, there were near 1,000. And now, if you were to search PubMed, which is where scientists go to look for clinical trials and other scientific evidence, you would see close to 3,000 clinical trials in the field of exercise oncology. So clearly, we feel we can conclude a few things. We know a little bit based on all this evidence. So the documented benefits of exercise during cancer treatment and after cancer treatment include, number one, cancer-related fatigue, which is a very common side effect, sleep, quality of life, anxiety and depression, body composition, physical function, and largely because of my own work, breast cancer-related lymphedema. There is other research ongoing. There are things that we don't know yet. And so there are other studies happening, including my own Thrive 65 trial, which is part of a large consortium called INICTO, Exercise and Nutrition Interventions to Improve Cancer Treatment Outcomes, that are focused on treatment tolerance. And we really think that if we can document that exercise has an effect on the curative care for cancer patients, that it will really blow the lid off of getting exercise oncology to be standard of care. So we have all these guidelines. I've talked about the ACSM guidelines, but there's also guidelines from the American Cancer Society and from ASCO. One of the things to point out about these 3 different guidelines is that the author lists do not overlap. So you have 3 different expert panels that are all medical oncologists and exercise physiologists and physical therapists and nurses and researchers and practitioners that have all drawn the same conclusion. The quote from the ASCO guideline that I love so much is that medical oncologists should refer their patients receiving chemotherapy to exercise programming to address common symptoms and side effects. So a little more about this ASCO guideline, just because it's a very important organization, very politically powerful, and so it's great that they did this. They looked at whether for adult patients receiving active treatment, whether exercise, diet, or weight control made a difference for outcomes related to treatment toxicity, quality of life, or cancer control. And what they were able to conclude, as I mentioned before, is that oncology providers should recommend aerobic and resistance exercise during active treatment with curative intent, and that it will make a difference in fatigue, fitness, physical functioning, strength, quality of life, anxiety, and depression. But what about diet and exercise? You might be surprised that this expert panel that was filled with nutritional scientists as well as medical oncologists concluded that there is currently insufficient evidence to recommend for or against any particular dietary interventions during treatment. I'm not telling you that we don't need nutritionists as we're going through our cancer treatment. What I'm telling you is that we need our exercise oncology professionals. There was also evidence that neutropenic diets, meaning diets that omit raw fruits and vegetables, for the purpose of decreasing infection, were not recommended during active treatment. And finally, there was a conclusion from this expert panel from ASCO that there was currently insufficient evidence to recommend for or against weight loss or prevention of weight gain interventions during active treatment. This is during treatment, not during survivorship. So I just think that that's sort of a public service announcement that I'm sort of summarizing that guideline for you all. So what's happening out there? 30 to 47% of cancer patients are adequately active. And as mentioned in the film, only 15% of patients report being referred to an exercise program by their oncologist. And so that's why when I was president of the American College of Sports Medicine, I started a new initiative under the auspices of Exercise is Medicine. And this was the first disease-specific initiative of Exercise is Medicine, and we call it Moving Through Cancer. So our goal with the Moving Through Cancer initiative is to answer the question and act on the question, what needs to happen for exercise to be standard of care in the setting of oncology by 2029? We asked this question in 2019, so it was a 10-year goal. So we decided that there were a number of agenda areas that we needed to address. The first one is stakeholder awareness. Sherry's film is an incredible addition to our efforts in stakeholder awareness. The average person on the street does not know that exercise is good for somebody who is going through cancer treatment, and we need to change that. Workforce enhancement, we need to expand the workforce of cancer rehabilitation specialists and exercise oncologists exercise oncology specialists across the US. We need to change policies and find sustainable funding options for exercise oncology programming. We have to develop more programs in places where there are not programs in existence right now, and I'll show you a map of those programs across the US in just a second. And of course, there's more research and evaluation. So I'm just going to touch for just like 3 minutes on some of the activities that we've done in the Moving Through Cancer initiative over the past 5 years. First off, we developed a brochure called Moving Through Cancer, and this is, lots of very colorful pages, very little text on each page, fifth grade reading level. It's been translated into Spanish as well. I'm happy to get copies of this into the hands of anybody that you think can hand it to patients. Very simple messaging. My favorite one being some movement is better than none. I love the quote in the film about we see the greatest effect going from the couch to the sidewalk or something like that. Couch to sidewalk?
Sofa to sidewalk.
Sofa to sidewalk. There it is. Exactly. And then, as mentioned at the end of the film, I have written a popular press book that's intended to be an easy button guide for people as they're going through cancer and beyond to get them moving and stay moving. I'm very proud of the policy work that we've done through Moving Through Cancer, including changes to the National Accreditation Program for Breast Cancer Standards that now require, in bold on this slide, exercise recommendations that must be documented within the electronic medical record for all women going through breast cancer treatment. If they're seeing a medical oncologist, there has to be something in the medical record about exercise recommendations. This went into effect in 2024. We're also working on submitting a national coverage determination to the Centers for Medicare and Medicaid Services, which would give us federal coverage for all individuals over 65 for exercise oncology services. As I said, we mapped all of the programming for exercise oncology across the United States. And the great news is that there were 2,133 programs across the United States, which sounds fantastic. And then you say, that's great, that's wonderful, we're done. Except look at how they're mapped. Look at where they fall. So the black specks are where the programs are. And the red areas are the rural areas that do not have a program. And the kind of purpley areas are, I didn't do this with anything to do with politics, I promise. Anyway, the purple areas are the urban areas that do not have any programming. And what you can see is that the programming is really largely concentrated along the coast in the Northeast, and that there are great swaths of places in the Western states in particular where there is no programming. And so we have to figure out how to get exercise oncology programming into places, particularly where it's rural and underserved populations. We did do a geospatial analysis of this map, and we are able to document that availability of exercise oncology programming does vary by socioeconomic status, by geography, rural versus urban, by neighborhood deprivation index, by cancer incidence, and by cancer mortality. I am very proud to say, however, that in the process of doing that map, we then developed a national exercise oncology directory. Rather than give you the website for it, because it's a very long website, I would say to Google Moving Through Cancer ACSM. That will get you to this. We are updating this with a triage tool soon so that it will be easy for you to know what kind of program would be most appropriate for you. And we will have an entry pathway specifically for patients, physicians, and exercise oncology professionals. I'll just finish up by saying that I am the founding director of the Moving Through Cancer team, but I am really, really proud to lead this international team of experts that include a medical oncologist, a behavioral scientist, an implementation scientist, a nursing researcher, a PM&R physician, a physical therapist, an American Cancer Society advocate, and a partridge in a pear tree. So there's quite a list of people that work on moving through cancer. So I'll finish now by just saying how grateful I am over decades of work in this area to have had amazing colleagues, trainees, and friends that have helped me to move this agenda forward. And if there's anything that you all can think of that I should be doing or that Moving Through Cancer should be doing in order to move cancer exercise into standard of care, I am absolutely delighted to hear about it. So thank you for your attention, and I think we can shift now to the questions.
Thank you so much. I mean, not just for your time today, which I'm very, very grateful for, but for your mission. I mean, I don't think we'd be here if your mission wasn't what it was and so successful. Okay, so if you want to our community, if you want to ask any questions in the chat, I could serve as moderator. And I'll start just while people are writing their questions with one question of my own. So this comes up for us, for me at least clinically often, where we know the guidelines talk about try to get at least 150 minutes of moderate aerobic exercise per week or 75 minutes of vigorous, and ideally to include 2 to 3 sessions of resistance training. How do you counsel individuals who are interested in interval training? Or do you think it's too complicated in a physician's office, and this needs to be relegated to the world of exercise physiologists, for example? And do you think it's more effective? I mean, do you think it might be more effective for some of the symptoms, or about equivalent to moderate aerobic exercise, let's say?
Yeah, I'm going to say that one of the things that I find most challenging about trying to make exercise standard of care is that if you have seen one breast cancer patient or one cancer patient, you've seen one. And so the difficulty is that we have people who finish their cancer treatment and were previously, competitive tennis players, and they're ready for high intensity interval training or any kind of interval training, and they are very kinesthetically aware, and we can refer them on. And then we have other folks that need help getting off the couch. And so I think that there's kind of two things that we need to be doing. One is an evaluation from someone like yourself or a physical therapist who can help to, see kind of where this person is and what is appropriate physiologically. The other thing is we have to follow Karen Bass-Nenquist's guide. She was the behavioral scientist in the film. She's from MD Anderson. And, she said, if somebody doesn't want to go to the gym, I don't just tell them to go to the gym. We have to find something that people like. And so if somebody wants to do interval training, my answer is great. Let's find interval training for you. But I want that person to have an evaluation from a physical therapist, from an exercise physiologist, from a PM&R doc, that understands how to evaluate their physiognomy to make sure that things are okay, and that they're ready to go do that level of training.
Okay, great. Thank you. I'm going to ask a couple more, and again, to our audience, feel free to put anything you'd like in the chat. Dr. Wo was alluding to this in terms of, and I know some of the Australians were literally having people on the bike 30 minutes before or after chemo. Are there any new insights on whether this is a promising kind of tool to actually improve outcomes oncologically? To have exercise like concurrently with chemo?
Yeah, the provocative work that I'm seeing is coming from Ricky Simpson at the University of Arizona. He's an exercise physiologist, and he is doing some really interesting work to see whether exercise close to the time when we harvest the T cells makes a difference in CAR T cell therapy. He just posted that he just recruited his 60th patient, which was the last patient in the trial. So I'm crossing all paired appendages right now that Dr. Simpson will have some findings for us soon.
Okay, well, we have a quiet group today, so I'm going to ask one more while we're waiting to see if there's anything else. Do you think there's any value? Actually, I have two more. In assessing body composition as a tool to kind of guide or motivate behavior? So either with a DEXA scan or an in-body, bioimpedance type device, is there value in checking these things periodically as you see things?
Absolutely, particularly in our older patients. We actually find that if people, we just don't know because somebody can be sarcopenically obese, meaning that they can be overweight in terms of their BMI, but actually have very little muscle mass as they're entering their chemotherapy, and then further lose more muscle mass and more function as they go through treatment, and we don't even know it. So knowing what baseline body composition looks like before we start treatment is an enormous help to understand what's happening and how chemotherapy is having an enormous effect on physical function and why it's having the effect it's having on physical function. So I think body composition is underutilized in the setting of clinical oncology.
And I'm curious, how do you check it? Do you use DEXA or InBody, something different?
Yeah, I would say, there's gold standard, and then there's what you actually have time and energy and resources to do. I think the InBody is a really interesting way to get it done in the clinic. It's not perfect, but it certainly is. I think it's very motivating as well. I think it also is a great way for us to understand, what the changes are as people go through treatment, as I say, so that we can understand whether we need to refer somebody for rehabilitation or exercise programming.
Great. Okay, I'm going to read through a couple questions. Somebody asked, is there hope for an 85-year-old man to rebuild muscle after significant sarcopenia?
Absolutely, there is absolutely hope for that man. One of my ongoing trials is for not men, but for older women and in breast cancer, and we're building muscle in these women, and they're going through chemotherapy, and we're still building muscle. So I think that one of the things that we need to make sure happens, Jennifer, is that we're making sure that we're monitoring what's happening with that person's protein intake. It's much more difficult to build or rebuild muscle if we're not taking in sufficient protein. And so there has to be a combined intervention of resistance training and protein supplementation generally. What we have found in our hands in the trial that I'm doing with Jennifer Ligabell from Dana-Farber is that the majority of older women going through breast cancer are taking in insufficient protein to be able to build muscle as they go through their chemotherapy. So the likelihood that an 85-year-old is not taking in sufficient protein is very, very real. So there's a big need for supplementation.
Yeah, we actually had a seminar about whey protein and bioavailable proteins for during chemo a few months ago. And I'll just add, there was recently a study I saw where they randomized, this was not cancer patients, but adults who were 65 to 75 to weight training versus 85 and older adults.
Wow.
The 85 and older actually made more meaningful improvements in terms of getting up from a chair and another kind of functional measures. So I completely concur. Okay. Do you have any advice on getting a prehab program started in a cancer center? What assessments would you recommend? This might be a complicated one.
Yeah. So I think that right now, based on our current reimbursement guidelines from CMS and from private insurers, if you can house it within a rehabilitation program, with physical therapists, occupational therapists, speech and language folks, that helps. I think that there are programs that are really arising mostly out of Canada that are doing, beautiful prehabilitation work with a combination of exercise, nutrition, and stress management, and can be, come sort of prepackaged to you from the groups in Toronto and other cities in Canada. And I think that the other big question that I would have for you is, do you have the buy-in from your leadership, and do you have a business plan and a return on investment plan? Do you know what space you need? Do you know what your staffing model is for how many people you think would come through? I happen to be building a curriculum to try to teach those sorts of things. So if you're interested, in that concept, I hope you'll be in contact with me because I'd really like to talk to you about it.
Great, thank you. Somebody asked about how, but with regard to financial barriers and recognizing that there are cardiac and stroke kind of exercise programs that are reimbursed, and how can we move the needle in this space?
Yeah. So again, physical therapists are capable of doing therapeutic exercise and being reimbursed by third-party payers. If there are known deficits, then people with cancer are eligible to receive physical therapy. The problem is that what physical therapists are able to get to and what they're able to complete in the amount of time that they, the amount of sessions that they have for what is covered by third-party payers is insufficient for getting people back to their function that they want to get back to. So that's why we have submitted a national coverage determination application to CMS to try to get reimbursement for exercise physiologists to be able to deliver exercise oncology programming.
Somebody else asked about a recent talk, I think it might have been my presentation, on body roundness index versus BMI.
I don't know body roundness. Tell me about that.
And I'm not actually sure. I was given a talk that BMI only gives you certain information, whereas body, it doesn't tell you about how much bone mass you have, visceral fat you may have, etc. So I think you already addressed that point.
Well, yes, and my hero in this area is Ilona Maher, who is a rugby player for the U.S. rugby team, and who is 5'10", 200 pounds, and it's all muscle. And she likes to talk about the fact that her BMI is 30, and she is not obese.
Right.
So BMI is only so helpful.
So on that point, so we know muscle mass is good, bone mass is good, and visceral fat, i.e. bad fat, is we want to minimize. How much subcutaneous fat is optimal?
Yeah.
Do you think anyone really knows?
I don't know that this is known.
I don't think it's known either, but I want to ask you since you're here.
Yeah.
Okay. Maybe last one. What about amino acid supplementation and creatine monohydrate to build with muscle building?
Right. So for amino acid supplementation, this is basically another way of supplementing proteins. And so that certainly makes sense to me. With creatine, what I can say is that the science around creatine tells us that if you are deficient in creatine, then supplementation is helpful. If you do pre-testing and you have adequate creatine already, then you're taking a very, very expensive supplement to your urine, and it's not going to do much of anything.
Okay, so maybe I'll ask the final question unless Sherry has any other comments. But this question comes from a recent study I saw, I think it was one of the British journals, where they were comparing with a meta-analysis the effects of different types of exercise and its antidepressant effects compared to, for example, SSRIs and exercise seemed to do better, especially if there was a synergistic effect with medication. But the type of exercise, and there are biases with this, that seemed to have the greatest antidepressant effect was actually dancing.
Dancing.
Now, have you, in your own work, has there been any research on dancing for cancer survivors and its impact or why it may have special benefits?
No, but I don't know if you know this about me, but I was a dancer before I was a scientist.
Oh, I did not know that.
Yes, I was a professional dancer in New York, a modern dancer. I was a Graham dancer. So I know of work on dancing and Parkinson's. There's beautiful work on dance and Parkinson's, but I am not aware of anybody having done any particular trials about dancing after cancer. And now I want to go do one.
Okay. I'd love to partner with you on that one if it ever happens.
Yeah.
I know you can't see everyone's faces, but on behalf of our whole community, I want to thank you both so much for giving of your time so generously. Sherry, maybe you could give the final word for this afternoon.
I would just say exactly what Scott said, and that is get moving. And it doesn't, if you're feeling down and out from your chemo, get moving can be as much as taking a walk around your favorite chair. If you're, once you've done that, I guarantee you're going to feel a little bit better and want to walk to the end of the hall. And Dr. Asher, you told me during my chemo to promise that if I had a really bad day, to walk around the block. And I only had 2 really bad days, but each time I walked around the block, I ended up walking 4 blocks to the grocery store. So I know I'm a one-off, but it works. And I would heartily suggest people get moving.
Thank you both so much. Thank you everyone for joining. We hope to see you for the next seminar. Have a wonderful afternoon.
Thank you.
Thank you.